Hi, today we're going to be talking about an osteopathic approach to torticollis, plagiocephaly, and otitis media. Goals of this lecture: we want to review and define common pediatric presentations of these three conditions, plagiocephaly, torticollis, and otitis media, go over the anatomy of these and why they are commonly seen in pediatrics, review some of the current diagnosis and treatments for these problems, and identify some common osteopathic strains and considerations within these presentations, and finally explain how the incorporation of OMT can best be used in the treatment of these conditions. We'll start with torticollis. Torticollis is a malposition of the neck where the neck is side bent in one direction and the head is rotated the other direction. This is really a sign rather than a disease itself and can be caused by many things. It typically involves a spasm of the sternocleidomastoid, though it can also involve the scalenes, which will also result in rib dysfunctions. So we may have actually caused this a little bit. In 1992, the APA recommended a back-to-sleep program, which stated that babies should only be placed on their backs when being put to sleep. This was designed to address sudden infant death syndrome, SIDS, and it actually decreased the incidence of SIDS by 40%. However, it increased the incidence of plagiocephaly sixfold and increased the incidence of congenital muscular torticollis by 84%. Note that CMT is defined as torticollis that develops within the first 8 weeks of life and may not be evident at birth, so it still falls under the term congenital muscular torticollis. However, plagiocephaly and torticollis are reversible, where SIDS is not, so the recommendation is still very important because of the drastic decrease in the percentage of SIDS. It just requires a little more education on ways for us to prevent these other problems. So here you see a list of differentials of several things that can cause torticollis in babies, all the way from congenital, neurologic, traumatic, inflammatory, and a few others that don't quite fit into all the other categories. I'm not going to read through all of them, but feel free to come back and review this slide at any time. But this gives you an idea of just how many things can play into the causes of torticollis. So talking specifically about congenital muscular torticollis, with a tumor of the sternocleidomastoid. It's really a pseudotumor of infancy, also known as fibromatosis coli. It's a fibrotic muscular tumor of the sternocleidomastoid consisting of myoblasts, fibroblasts, and mesenchymal cells. And you can see it over here in this picture, just this bump in the middle of the sternocleidomastoid. It generally causes a fibrosis and thickening of that sternocleidomastoid, which results in that contraction on that side of the neck, pulling the head towards that shoulder and rotating the head away from it, and can progress to a complete fibrosis and contracture if it's left untreated. Can actually be treated with osteopathic manipulation, though if it's gotten severe enough, they sometimes need to go in and actually do a surgical correction. So what do we do for torticollis? Treatment of torticollis is multifactorial. We really need to identify what the underlying cause is in case it's something other than just a muscle spasm, and if so, that really needs to be addressed. Please refer back to the huge differential list that you saw a few slides earlier, all those other causes. We also want to look at identifying any cranial strains, commonly the cranial base, occiput, condyles. All of these areas are important because they can actually be a primary cause of this contracture into the sternocleidomastoid. Testing of both sternocleidomastoid and the scalenes and treatment of both as needed. And remember to check for the interplay of any cervical, ribs, thoracic, inlet, thoracic strains. All of these can really affect the sternocleidomastoid and the scalenes and really contribute to this condition. And we need to make sure that we've treated all those connections. What can parents do at home? Education for the parent is really key because these issues are very often related to positioning at rest. We encourage supervised tummy time, which involves laying the baby on a blanket on their tummy. It lets them brace themselves up with their arms and push their head up and their upper body, which is kind of like a mini push-up. Allows them to strengthen their extensors and reduce a lot of the time spent laying on that one side. And this is typically recommended around 3 to 4 months of age. We also recommend placement of mobiles, mirrors, and anything else that you can on the other side of the crib than where they typically are, because if the baby is commonly looking one direction, this will encourage them to look the other way. Cushions and pillows in the crib are really not recommended as they are actually a suffocation risk, so do not advise propping the baby up to make them look the other direction. Along with the tummy time, we encourage playtime in which toys and sounds are used to also encourage them turning their head to the opposite direction, even when they're laying on their back on a blanket. And we'll recommend very gentle stretching at home. Please keep in mind, if you're going to recommend the stretching at home, it's something that you need to demonstrate in the office, should be demonstrated by the physician, and the parent should demonstrate it as well in the office before they go home so that you know they're going to be doing it right. Moving on to plagiocephaly. Plagiocephaly is defined as an abnormal shape or deformity of the skull. It can be differentiated into primary and secondary. Primary plagiocephaly is a deformation due to abnormal intrauterine lie or a result of the forces of labor and delivery, and can be noticed directly at birth or very shortly after. Secondary plagiocephaly develops secondary to forces from things like torticollis and abnormal posturing. Not usually noticed until the infant is several months old. It takes time for it to develop because of the positioning. And you must always be on the lookout for craniosynostosis. So what is craniosynostosis? It's a premature fusion of the cranial sutures that results in abnormal head shape that has features that are decidedly different from that of plagiocephaly. Growth along that suture line will cease, and growth of the non-fused areas will continue, which results in significant deformity of the skull. The most common suture involved is a sagittal suture, also called scaphocephaly. It can be part of a genetic syndrome in which several other features of that syndrome are present. Or it can be non-syndromic, which usually only involves one suture and is more related to mechanical forces, actually abnormal stretch forces, not compressive forces, will signal premature ossification along that suture and result in the craniosynostosis. So how will I know if it's craniosynostosis? Signs that can make you worry that it's craniosynostosis rather than simple plagiocephaly include slowed growth of the head circumference. It may stop completely, and this is something you'll see over time as they come in for their well visits. They can have a palpable bony ridge along the fused suture line, worsening of the deformity. They can actually start showing developmental delay and abnormal hair growth patterns. It is recommended to do a CT for evaluation of this. Head CT is worth the radiation in this situation because the condition is very serious, but you definitely need a high suspicion to go for it. You don't get a CT of every unusual shaped head, especially if you can rule out craniosynostosis and be more certain that it's plagiocephaly, because we like to avoid radiation in kids. But this is one situation where it's definitely worth the risk. Treatment for this is surgical, and the surgery for it looks really drastic. It's not a fun one to look at, but it's very important that it be done. They actually have to separate the sutures in that skull and will actually remove part of it while they're working on it. Very drastic. So when you're looking at plagiocephaly versus craniosynostosis, one of the factors, and it's not 100%, but one thing that can help you sort of see it a little better is this parallelogram shape where there's not a change necessarily in the growth along the suture lines, but just an abnormal positioning, versus the synostosis where there's actually restricted growth along the suture line and everywhere else is growing out to allow for the expansion of the head. So you see exaggeration along all the other lines, but not along the suture that is fused. So here I've included some pictures of a kid with plagiocephaly and a couple versions of craniosynostosis along different suture lines. Here we see that parallelogram shape. So some frontal bossing, but overall good head growth, just in this slightly different shaping. Here's a picture of the scaphocephaly, the sagittal suture. You can see a sort of cranial ridge at the top of the head, and on the picture off to this side you see how the head is growing lengthwise, but not really growing out along where the sagittal suture would allow growth. This one doesn't really fit into that trapezoid picture, however the coronal and metopic sutures do. You can see the coronal restricted really just on this one side of the coronal suture, allowing for growth along all the other sutures here. And the metopic, which doesn't fuse immediately, and actually 5 to 10% of the population, even as adults, don't have fused metopic sutures. In this case, if it fuses too early, there's a decreased growth along the forehead, but the rest of the head is expanding out. Okay, so we've done our evaluation and decided that it's just plagiocephaly. Now what? Treating the patient involves first identifying any reversible causes and educating the parents on ways that they can help at home. Causes of plagiocephaly are varied. Patients subjected to abnormal forces in utero, torticollis, trauma, consistent back sleeping, which is still recommended and not a bad thing, prolonged time in car seats without changing positions, limited tummy time. In reality, most of the positional issues that we use for treatment of torticollis are also used in plagiocephaly, since one can actually cause the other. So having the patient changing positions more often, still recommending the back to sleep, but encouraging more tummy time, playing with the baby in ways that make them turn their head to the other direction, putting mobiles and things on the other side of the crib, things that are going to help with that positioning. If they're always in the car seat in a certain way, trying to change the positioning in that, and again, encouraging them to look the other way, put the car seat on the other side of the car if possible, and just trying to change things up so that they're more likely to turn their head evenly. All of these things can really help with treatment. If there's any problems with severe or unresolving plagiocephaly, they may actually require helmet therapy. The patient is fitted for a helmet that places very gentle pressure on areas with bossing while creating space over the flattened areas, and it allows for those areas to expand into the helmet. As the patient head grows, it will ideally develop into those areas where the space is provided, which will resolve this flattening. Helmets are not a static thing. They're modified regularly as the patient's head changes. They have repeated appointments to file away parts of it and sort of guide this development. It can result in some pressure sores, though the helmets are a lot softer than you might think. If you ever get the chance to actually look at one, they're a lot softer than you would expect them to be. So it's very gentle guiding and really not a bad treatment choice if they're having severe unresolving plagiocephaly. So then where does OMT fit in? As underlying cranial strains can lead to plagiocephaly, addressing these early can allow for faster resolution. Plagiocephaly that develops due to positioning can cause further craniosacral strains and prevent resolution or cause other problems. So while they're developing plagiocephaly and while they're being treated, other strains can spring up from this positioning. So it's important to kind of keep a good close eye on that and working through those mechanical strains. Other issues such as torticollis that are causing positioning issues are easily addressed. BMT, which is balanced membranous tension, which is the term we tend to use more when we're treating cranial versus the rest of the body. Soft tissue treatments, myofascial unwinding, all of these are really effective treatments. There's no specific treatment to do. It's the idea of identifying the different strains and addressing them to optimize the movement. Of note, patients receiving helmet therapy should still be treated with OMT. They really work well in conjunction with one another, and ideally the helmet adjustments should happen after they've been treated with OMT so that you're getting everything working a little more fluidly. You've resolved some of the strains and may have changed a little of the positioning of the head even with that one treatment. So then the helmet can be filed correctly to fit where they are at that moment in time and allow for better development over time. This is a picture of a beautiful baby of a friend of mine who received helmet therapy, so you can get an idea of what the helmet itself looks like. And he actually developed his plagiocephaly due to an extended stay in the NICU for other issues, so his positioning was very appropriate. He couldn't really be turned at the time, but this is what resulted after. So if we have somebody with plagiocephaly, we're seeing no change with the shape with OMT, physical therapy, and positioning, it is appropriate to get some x-rays just to make sure that there isn't an underlying craniosynostosis, even if there hasn't been other evidence of it to date. Getting x-rays and the 3D CT of the head, again, appropriate if we're not able to visualize the sutures well with x-ray. If the sutures are fine, continue with OMT and introduce the helmet therapy. It's best if it's initiated at like 4 to 6 months of age. And just of note, 85% of postnatal head growth happens within that first year of life. So we want to make sure we address it within that first year, because otherwise they have a chance of having some other cosmetic and facial deformities if not addressed in time. All right, so moving on to our last topic, which is otitis media, aka middle ear infections. It's an infection of the middle ear. Most common bacteria that you see in it are strep pneumonia, non-typable H. flu, and Moraxella. Although viral infections are more common than bacterial, however, when bacteria do spring up, these are the three you're most likely to see. It's classified as acute otitis media, chronic, or recurrent with effusion. And it's important to note that the infusion can remain after an infection is cleared up for up to 3 months in 10% of children, and still up to a month in 40%. So a lot of times people are diagnosed as not being treated or having another ear infection just because there's fluid there. But if they have no other signs or symptoms, they may actually just have fluid left that's not infected at the time. If you need to use antibiotics, the first-line antibiotic treatment is high-dose amoxicillin. And AAP guidelines published in February of 2013 did discuss the proper diagnosis and treatment of acute otitis media, including when observation is appropriate versus the introduction of antibiotics. This inadvertently happens to be a really great time to introduce OMT because if you're not treating them with anything else, you may be able to resolve the infection before it gets worse, saving the use of antibiotics, and the parents feel like you're still doing something, which is more amenable to them. And again, a lot of times people end up prescribing the antibiotics simply because of pressure from the parents, which isn't the appropriate way to do it, but the parents can be extremely persistent. So we first have to look at the anatomy. Why do we get ear infections and why are kids more prone to get them? The anatomy of the ear in childhood really sets the stage up for these more frequent ear infections. Our eustachian tubes run from the middle ear along the petrous portion of the temporal bone, across the petrous-phenoidal junction, past the palatine muscles to end in the nasopharynx. These serve to drain fluid that accumulates in the middle ear and allow air movement to regulate pressure. Think about when you're in an airplane, really excited when your ears finally pop and you get rid of all of that pain from going up or down in the airplane. The narrowest point of this pathway is over this petrous-phenoidal junction, where the tube is surrounded by a sling of connective tissue. So it's a common area for a lot of tension to really get hung up. Thinking about this, a lot of myofascial and cranial strains through this area can really impede the function of the eustachian tube. Overall, the heads of kids are just different. The development of the skull from childhood to adulthood changes the location of the ear in relation to the nasopharynx. In children, the eustachian tube is much more horizontal. As we grow, the face will elongate. You can see here where the eustachian tube's way down here. Over here, it's way higher up in relation to the rest of the head and the jaw and the nasopharynx. So as we grow, the face elongates, and it moves sort of forward and up and down a little bit more, so the ears will end up higher in the skull. This results in a better angle of the eustachian tubes that allows gravity to assist with this drainage. It becomes a lot more evident after 6 years old, at which time we tend to notice a significant decline in the number of ear infections in general. So then we also have muscles that are involved with this. The tensor veli palatini attaches to the lateral wall of the eustachian tube at the nasopharynx and opens the tube when it contracts. It works to help pump the tube to assist with drainage. So in kids, both floppy musculature and hypertonicity of this muscle can really affect proper functioning of the tube. If the muscles are floppy, they actually aren't opening and closing very well, so they're not allowing for proper pumping in the tube. Particularly in kids, if they're hypertonic, this really affects proper functioning of the tube because in kids, the eustachian tube is much more pliable, so a hypertonic muscle will actually distort the tube and alter the normal draining of it and will actually restrict their ability to drain because it over-distorts it. Another muscle we don't think about much is the medial pterygoid because it runs right by the opening of the eustachian tube but really doesn't play into it. However, it can actually have fibrous attachments to the opening of the tube, and when it contracts, the bulk of the muscle can obstruct the eustachian tube. So even though it's not a normal player in it, it can significantly affect it. Another thing to keep in mind is that the mucosa of the middle ear and the eustachian tube is pretty much the same as the mucosa of the nasopharynx. It's lymphoid tissue with secretory glands. So if the nose is irritated and producing more mucus, the ear is doing the same. Chronic stimulation of this area results in increased viscosity of the mucus produced. The longer this mucus is sitting there, the more likely it is to breed nice, healthy bacteria, which is not so good for the host, but it's great for causing a major ear infection. So OMT to the rescue. OMT in the presence of acute otitis media is used to promote drainage of the fluid and reduction in viscosity of that fluid. The common areas that we like to treat in this case are any cranial strains, medial pterygoid, the cervical musculature, thoracic inlet, OA and AA, and the upper thoracics. Don't forget your viscerossomatic and autonomic influences from some of these regions as well. This is very helpful in reducing the amount of fluid accumulation in the middle ear, allowing for faster resolution of the infection, and reduction of recurrence. There's a couple techniques that we will go over in lab that really help address this area and can very much help with draining the middle ear as well. Keep in mind, OMT does not replace the use of antibiotics, which are still very appropriate for some patients and situations, but it may reduce the need for them overall. And even if you start antibiotics, OMT is still very useful when they're being administered because it does still help with the overall drainage and lymphatic flow, so it's still important to use to help the antibiotics do what they need to do. So it may still help reduce the course of the infection, not the course of antibiotics. They should always be taken the complete course they're prescribed to reduce the incidence of resistance, but it's not one or the other. OMT is appropriate throughout, whether they need antibiotics or not. It can be very useful. So this concludes my lecture. I hope you've gotten some very good information about treatment of and better understanding of the causes and the treatment for otitis media, plagiocephaly, and torticollis. Thank you very much.